Thank you for that very kind introduction. I'm really excited and humbled to stand here on this podium today. And this is my topic, which is related to latest and the greatest in cardiac device infections. Why am I here to answer that? I need to take you back 20 years ago. This is 2005 at Mayo Clinic in Rochester, Minnesota. We are sitting in the St. Mary's cafeteria. It's minus 20 degrees outside, what we call summer in Rochester. And Larry was my mentor, and he was also the chair of the American Heart Association Committee on Endocarditis. So I asked him, I'm interested in CV infections. What do you think would be good field to study? And his usual deep signature voice, he said, Riz, I think pacemaker infections, we need to learn a lot about that. He sounds better than that, but So I said, yes, sir, I'm on it. So now, 20 years later, and 200 publications after, I'm going to share with you what I've learned about pacemaker infections in the last 20 years. Here are my disclosures. And I have a conflict of interest with everyone who mismanages device infections. So what are the learning objectives today? So I hope that the conclusion of this session, you're able to understand the epidemiology of device infections, choose the right test to diagnose infections or rule it out, learn how a multidisciplinary approach works to manage these infections, and finally understand some preventive techniques to prevent device infections. But really, like I really want to achieve at the end of this hour, that when you step out of this auditorium and you go see your next patient with device infection, you at least think or do one thing different based on what you've learned today. And if I can achieve that, I think that'll be a success for me. So yesterday I was walking through the Wallace Wilson Museum upstairs and looking at all these devices. So I took this picture, and I think it's quite remarkable that in the last several decades, how much advancement we've had in devices. We are far advanced than these bulky 8-inch wide generators that we used to have decades ago. The devices which are much smaller, we're implanting millions of those devices every year globally. And there's a lot more experience in implanting those devices. So one would expect that with this volume of experience, with advancements in technology, manufacturing, smaller size, you'll have less infections. But is that true? So we did a population-based study in Minnesota looking at the last 3 decades. And what we found is that across the board, whether it's pacemakers or ICDs or CRTs, the trend is upwards. You're seeing more infections. Why is that? I don't think there's a singular explanation for it, but in general, it seems that it's being driven by devices being implanted in patients who are much older, in their 80s and 90s, getting their first device. They're much sicker. They have lots of comorbid conditions. They end up in the hospital frequently. Their wounds don't heal. They get bacteremias, and then they get infections. So it's estimated that more than 1.5 million of these devices are implanted across the globe every year, but 1 to 4% get infected. And why do we care about infections? It's because these patients, if you don't manage them well, they can die. These are difficult to treat infections. And last but not the least, they're quite costly to manage as well. So we did a study looking at MarketScan database. It's a peer-based database. We looked at the records of 97 million Americans through that database. We found 60,000 de novo implantations and 30,000 replacements. And we found that the infection rate was like 1.18% for new devices and 2.37 for the replacements. And looking at the cost for a non-infected device implantation or replacement, it's around $50,000 to $60,000. But if you have an infected device and you're replacing that, this additional $50,000 cost to it, because you have to remove the infected device, treat it, and put in a new device, which also costs $50,000. But these patients tend to stay in the hospital for 2 to 3 weeks because they come in, you initially do 2 to 3 days of blood cultures, then you get the EP consult, you get the echo, you plan for extraction, and then you repeat blood cultures post-extraction, you're giving them antibiotics, waiting for cultures to clear. Other things go wrong, the kidney starts to fail and stuff like that. And there's significant mortality, especially with systemic infections and Staph aureus. Even once they survive the index hospitalization, they're high risk for death in the next 3 years. Half of them do not survive. And that's just a reflection of how sick these patients are at baseline, that even when they survive the infection, due to their comorbid conditions, their long-term survival is not so good. And because I want to keep the talk more practical rather than a lot of just data, we'll go straight on to diagnosis. So the latest version of AHA guidelines for CIED infections was published in 2023, unfortunately, because we wanted to publish it in January 2024, but got published online a month earlier. So instead of 2024, these became 2023 guidelines. So timing matters. Here are the guidelines and the algorithms in it. I'm showing them just as a reference because I want to actually talk about where do these guidelines come from and how do you actually manage these patients. So when you look at the pocket infections, mostly it happens because the device or the pocket gets contaminated at the time of implantation. So you get superficial infection, it can go deeper, involve the pocket, and if you do not treat it in time, the leads can get colonized as well. And occasionally the bacteria can track along the leads and end up in the bloodstream. And you develop a bloodstream infection, you can develop lead vegetations, and it can involve the tricuspid valve as well. Pocket infections are typically easy to diagnose. It's a clinical diagnosis. I showed this picture to my daughter when she was in 5th grade, and I said, "What do you think?" And she said, "It looks infected." And I said, "What should we do?" And she said, "We should take it out." And the surprising part is it takes us a lot of convincing to people practicing for decades to take these out. So there's some disconnect between what the ideal treatment is and people trying to still conservatively treating them. But sometimes pocket infections can be difficult to diagnose because you can have a little bit of redness at the pocket. Maybe it's the erythema due to adhesive that you placed. Maybe it's the little bit of stitch abscess at the suture site, a reaction to the iodine or antiseptic agent that you used, and occasionally allergic reaction to the components of the device itself, whether it's cobalt or nickel or polyurethane or silicon or titanium. So sometimes it is a little confusing that whether infection is superficial or deep. In those cases, I think perfectly reasonable to give them a course of antibiotics for a week or 2. But the key is to bring them back and take a second look. If infection has resolved or redness is gone, then you get the problem. What happens is that people are given a prescription and forgotten about it. Then they come back 6 months later with a draining sinus and pus pouring out and systemic symptoms. That's what we don't want. But things get a little more trickier when you're talking about systemic infections. So these are the situations, patient gets infection somewhere else. Skin and soft tissue infection, maybe with Staph aureus. It's not managed in time. So these patients can get bacteremic. And as the blood flows through every organ, including the heart, Staph aureus and some of these staphylococci and Pseudomonas and Serratia can be sticky. So they can stick to these leads during an episode of bacteremia and form the vegetations on the lead or the valve. But now the question becomes that if you have a patient who comes to the hospital and positive blood cultures with something, and the pocket looks fine, are we supposed to look for lead infection in all of these patients and take them out? Or is there a better way to think about it? And I will submit to you, it depends on the specific organism and the situation. So we'll go through some cases. So this case is a 72-year-old male, diabetic with heart failure, comes with lower extremity cellulitis, kind of the person I showed you the animation about. He has a CRTD in place, blood cultures are positive. You look at the patient, examine, the pocket looks just fine. There's no stigmata of endocarditis on exam. So what should we do? Should we just put a PIC and just give a longer course of antibiotics? Take it out because Staph aureus is high risk and sticks? Do a TEE to guide the management? Do a PET scan because TEE can be non-specific sometimes? Or give a longer course of daptomycin and rifampin? So I want you to think about the answer and we'll come back to what the data shows. So we did one study called PREDICT, which is a prospective study. We enrolled patients at 3 sites at Mayo Clinic and tried to come up with a prediction algorithm for this specific situation, a patient with Staph aureus bacteremia and a normal-looking pocket on exam. So we had 131 patients. 1/3 eventually were diagnosed with CIED infection based on the echoes or PET scans, the persistent bacteremia, and different reasons. But when we were trying to develop predictors, while we found some, which is type of device, revisions, multiple days of positive blood cultures, we couldn't find specific patients where even if the predictors were negative, the risk was 0. So you could still miss cases of Staph aureus lead infection if you only go with clinical predictors. Therefore, a subsequent study was done, which was published in 2021 by the same group at Mayo. So looking at 110 patients with Staph aureus bacteremia, normal-looking pocket, and 50% had definite CIED infection, and almost 30% had possible CIED infection. That's 80% of the patients with Staph aureus bacteremia. So 4 out of 5 possibly or definitely have underlying lead infection. Therefore, for Staph aureus, the lead and the device is infected until proven otherwise. So you have to look and rule it out. And it was also interesting that for definite cases, if you did early extraction, there was an 83% reduction in 1-year mortality. So it's really important to diagnose and treat and remove in a timely manner. So in this particular case, the answer is you do a TEE, that's step number 1, and you go from there. And we'll talk about what else to do if TEE is non-diagnostic. So case 2, 55-year-old dialysis patient, misses a dialysis session, and so feels more short of breath, is not feeling well, shows up in the hospital complaining of shortness of breath. The on-call person took some history. Patient said, sometimes I feel chills at home, has no fever documented, normal WBC count, normal CRP, but they get the blood cultures and they start patient vancomycin. All right, and then, of course, before the susceptibilities and ID of the organism is back, is GPC, the echo is done, and now it shows a vegetation on the ventricular lead, cannot rule out infection. So what do you do in these cases? So for non-Staph aureus gram-positive bacteremia, it's dependent on which organism is it. So for Coagulase negative staphylococci and enterococci and viridans group, these blue bars show how common underlying lead infection is. So it's quite a bit, somewhere between 15 to 30% of these cases have infection. Other organisms, not so much. So for streptomitis, mutants, etc., it's very uncommon to get lead infection. The other thing to think about in these patients is that when you do TEE, you start to see things. So there's good literature that 10 to 15% or more patients with the devices have something on the lead if you start doing TEEs on everyone. All right. So we did a study. It was actually led by a med student, Merritt George at Mayo Clinic. And so we took 50 cases, 25 with well-known established definitive infection because of persistent bacteremia and clinical findings and treatment response, and 25 cases who had TEE done for AFib or other indications. We took this 50 echoes, we gave it to 2 echocardiographers at Mayo, excellent credentials, some of the best folks, and asked them to read these echoes blindly by each of them and looked how good they were in distinguishing lead infection from non-infected masses on the leads. And they couldn't. There was no significant difference in the size, mobility, and texture of the echo densities in infected cases and non-infected cases. Only a quarter of the infected cases were correctly called as infected vegetations, and there was quite a bit of disagreement. So therefore, you should not start doing echoes in everybody if the clinical context does not make sense. So in this particular case, ID was consulted. We felt there was 1 out of the 4 positive blood culture with coagulase negative staph. There was no other signs or symptoms of infection. So we thought this echo density was non-infected, decided to give no antibiotics, and the patient did just fine. Okay, now case 3 is a 67-year-old female, diabetic with CKD, comes in with classic symptoms of pyelonephritis. CVA tenderness, toxic appearing, blood cultures are positive for Klebsiella, and urine cultures are positive for the same organism. So what should we do in this patient? We think Klebsiella can be sticky, so we should rule out lead infection, give a longer course of antibiotics because we want to make sure that we've taken care of it, do a PET CT to rule out infection, just remove it because Klebsiella is high risk amongst the gram-negatives, or just send patient home on antibiotics, PO, because patient's been afebrile for 3 days. So what does the data say about this? So we did look at this for gram-negative bacteremia and risk of seeding. 126 patients, only 4 out of those 126 had evidence of CIED lead infection on extensive testing. And these black bars basically mean no infection, and the white sections mean infection. So only in Serratia, there was a little bit of correlation between risk of seeding. For other organisms, it wasn't. There was a similar study done at Duke looking at different kinds of cardiac devices, and they found Pseudomonas was also high risk. But Pseudomonas and Serratia, high-grade bacteremia with no other source, was the only situations where gram-negatives would be causing infection. Otherwise, you could ignore most of the other gram-negative organisms, just treat the primary source, and they did just fine. So in this particular case, we'll just send the patient home because we have another source, it quickly cleared. Klebsiella is actually not high risk for seeding, so we do not need to investigate for underlying lead infection. So another case is a 43-year-old female with Crohn's disease, has a central line for TPN, has a pacemaker, and positive blood culture with Candida. So what do we do about Candida in presence of a device? So we looked at that smaller study, few patients, total of 23. What we found is that eventually with, after all these attrition diagrams and looking at this complex algorithm, 18 to 20% with Candida will have underlying lead infections. That's 1 in 5. So we feel that patients with candidemia, especially if it's high grade or recurrent, you need to look for underlying lead infection and remove the device if necessary. This is sort of one algorithm that puts all of this together, what organism it is and what situation it is to help you guide decision making. But what about those situations where bacteremia is there, echo is, not sure, there's some thickening of the lead structure, then maybe there's some valve thickening, you're not sure, high risk organism, there's no other source, you're trying to figure out, is the device infected or not, and should I take it out? Then PET scan can be helpful in those situations. We did a meta-analysis of the published studies. It had around 500 patients. What we found is that PET is excellent for pocket infections. So if you have a deep pocket infection and you're not sure about it, PET can help you rule in or rule out. For lead infections, it's like 70%. So you can still miss some cases of lead infection based on how PET scan is usually done. All right. And the problem here is that myocardium is metabolically very active. So when you do PET scan, everything lights up in the heart. So how do you see the 2-3 millimeter vegetation on the lead when everything is lighting up? So one of the ways you can make the PET better is to use what's called sarcoidosis protocol. So what you do is that you starve the patient for a day and then put them on ketogenic diet. So they go into ketosis. So the heart will switch to ketones as the source of energy. So the next day, when you inject the FDG glucose, neutrophils and bacteria will pick it up, but myocardium will take a few hours to switch back to glucose as a source of energy. So the infection side and the neutrophils and bacteria will light up, and the rest of the heart would not. So in this, on the right, you see there's valvular and perivalvular infection that you can see in the PET scan, but the rest of the myocardium is quite silent. This particular patient also has CML, so what uptake that you see in the spine is not due to metastatic seeding of the spine, it's the malignant neutrophils there picking up the FDG glucose. As a result of all these data for PET scan, the 2023 Duke criteria now includes PET scan as one of the major criteria for endocarditis and device infections. But we in infectious disease also not only want to know if the device is infected, but what's the cause, what's the organism, especially if blood cultures are negative. And that's where sonication can help. This is a process where you take the device out, you put them in ringer lactate, you apply high-frequency ultrasound waves on it, which helps to break down the biofilm, just like you're trying to do lithotripsy, right? So when the biofilms break, the bacteria are released in that solution, you centrifuge it and culture the sediment. And here you can graphically see how much sonication can help you grow the organisms compared to tissue cultures or swab cultures. So this can be really helpful. So in one study that we did, we found that half the cases which would be otherwise culture negative, you can detect significant growth of organisms by doing sonication process. Now, this is not something unique just to cardiac devices. Similar data has been shown for prosthetic joints. Same situation. A lot of times you have culture negative prosthetic joint infection because before the surgery is done, patient is already on antibiotics for several days, which makes the tissue cultures negative. We also sonicated the dummy devices to make sure that we're not picking up a lot of colonization, and we did not. Doing PCRs on the sonicate fluid can help to detect some additional organisms, but it's not a magic bullet, so you don't always find the cause of infection doing PCRs. So it has its limitations, but can be helpful, especially in situations where patients are colonized, known to be colonized with MDR organisms. You know, this patient had MDR Klebsiella in the sputum or something else in the urine, or the wounds, and now you're trying to figure out the device cultures are negative. What do we send patient home? Do we need to send them on meropenem, cefepime? Is levaquin good enough? So in those cases, you know, digging deeper, doing PCRs can be helpful. But as I said, PCRs can also be negative in many situations. The blood cultures can be negative in many situations because patients have received antibiotics from their PCP. They got a prescription of macrolide or levaquin or something before they came to the hospital, which made the blood cultures negative. And there, the metagenomic testing can be helpful. Now, when we talk about genomic testing, we're thinking about specific organisms that we're trying to find by doing certain PCR methods like 16S, 28S, 23S. Metagenomic is when you're trying to find any DNA that you can find in that plasma, amplify it, sequence it, match it to your database to see what that is. So just last month, we had a patient who came in with no fever, no leukocytosis, just feeling unwell and have worsening heart failure. No epidemiologic exposure. So we didn't know like which serologies and PCR should we send, but had a pretty big vegetation on the valve. And so we decided to send the plasma microbial cell-free DNA, and we found Q fever as the cause of infection. So for culture negative, and this is really transformative because the treatment is so different. For Q fever, you would give 2 years of combination of antibiotic therapy compared to ceftriaxone or vancomycin for a couple of weeks that you'll give for usual strep or staph infections. So when in doubt and the infection is serious, I think going further can be helpful. And so I'm glad to have one of my colleagues, Dr. Khalil here. She's also interested in metagenomics and cardiovascular infections. She was actually my research fellow when we were at Mayo Clinic, and we were very glad when she joined faculty here. So she's currently leading the largest multi-center study in US on metagenomics and cardiovascular infection. And she's published already quite a bit on the subject. So we were hoping that this technique can be applied in cardiac device infections. And one of the unique angles I think we could potentially look at is this is a pilot study that was done at Harvard. And it's very interesting how they approached metagenomic testing in these cases. So they had 22 patients with staph bacteremia. Eventually, 11 were classified as definite and 5 as possible cases using the European Heart Rhythm Association guidelines. All right, so definite cases are quite straightforward. Staph aureus bacteremia, lead vegetations and echo, multiple days of positive blood culture, 3 to 5, 10 days. So it's pretty straightforward. There's no question about it. They did serial testing, and they found that these patients had persistently detected DNA until pre-extraction. On the day of extraction, they will have a peak, a spike on their DNA level, because as you're extracting leads, putting laser sheets, you dislodge the vegetations and the biofilms, and temporarily the bacterial load in the bloodstream goes higher. And then after extraction, it'll go down. And this is just a graphic representation of that. What's really interesting is what would be classified as possible cases. And they seem quite compelling to me. You have Staph aureus bacteremia, high risk. You have 1 to 3 days of positive blood culture. 3 of these patients have a positive echo. So one would think, this is a pretty compelling case. These cases should be managed with device extraction. They did serial DNA testing on these. So on the day of the consent, because the blood cultures were already negative, they had received 5 to 7 days of antibiotics. Only one of them had positive DNA level. And in the next 3 to 4 days on serial testing, they were all zeros. On the day of extraction, they were all zeros. And post-extraction, they were all zeros. So this makes you think that, could we use serial testing to make a distinction between real infected cases versus possible cases which could be rejected? Because, as much as I would want everybody to remove infected devices, we don't want to unnecessarily remove devices. It's a big procedure. Many of them have leads for decades. It's their 4th device, their 6 leads. 2 are, tangled with each other. 3 are attached to SVC. So this is not like easy procedures to do in every patient. And they need the device. That's why they have it, at least for most part. And could this technique then be expanded to maybe vascular grafts or LVADs? We deal with a lot of these situations where patients are bacteremic. They have a device in place. They're trying to figure out, is it seeded? Is it not seeded? Imaging is not always helpful. So I think potentially, and we would love to collaborate with anybody here who wants to kind of work with us and enroll these patients and do actually prospective clinical trial and see, could this be helpful to manage our patients? And we kind of wrote an editorial about it as well. So this would be a proposed study that patients come in, there's bacteremia, but imaging is not convincing, or bacteremia is short-lived, and could we do serial testing and based on that make a decision to either extract or leave it in and just follow them up, treat, and bring them back and check for relapses. All right, now about the management part. If the device is infected, it's pretty clear. There's tons of data that you need to take it out, no question about it. Majority of these are caused by staphylococci. So if they come in and you need to give empiric therapy, usually vancomycin or something like that is enough. You do not need to routinely start them on meropenem and cefepime and something else because gram-negative infections are quite uncommon. The reason they do not get better with antibiotics alone is back to that biofilm situation. So when the staphylococci or pseudomonas or serratia, the high-risk organisms, when they bind with the leads, they make this biofilm or glycocalyx. It's just that slime layer, bacteria get embedded in it. And it's a multi-layered structure. These bacteria talk to each other. They have this coordinated plan of how to stay attached to the leads. So that creates two problems. First of all, the antibiotics do not penetrate the biofilm very well. So beta-lactams or cell wall active agents that we use don't get inside the biofilm. Second, the bacteria at the bottom of the biofilm, they're just anchoring to the device surface. They're not replicating or dividing. Their job is just stick. It's the bacteria on the surface layer which are expanding to grow the biofilm. So antibiotics, the beta-lactams and cell wall active agents are really good at killing bacteria which are dividing and replicating and making a cell wall. They're not really good at killing bacteria which are just sitting there dormant, metabolically inactive. So for these two reasons, it's very difficult to cure these biofilm-associated infections with just antibiotics. As I said, lots of data that if you try to manage them with antibiotics alone, there's 7-fold higher mortality and 80% risk of failure just with antibiotics. So it should really be your option number D or E if patient refuses or for some reason just can't take it out. Also, in cases of systemic infection, especially with Staph aureus, you don't need to just take them out, but need to take them out as soon as you can. The longer it stays in, the more likely it'll seed other organs and infection will get complicated. In the 90s, when there was quite a bit of debate to take them out or not take them out or try to manage them, these data was quite compelling. And the first one, which was in circulation in 2001, 47% mortality for Staph aureus bacterium and lead infection if managed with antibiotics alone versus 16% with extraction. In the next one, the mortality was 66% with antibiotics alone and 18%. This is Staph aureus, but this is one of the common high-risk organisms we deal with. So with all this data and publication and guideline after guideline recommending the same thing for 2 decades, you would think that every patient with systemic infection is getting extraction. That's just not the case. This data that Duke presented, now granted it's based on ICD codes and pair-based, so it's not exactly a clinical database, but it's good to look at the trends. And the trend is like only 18% are getting extracted even when they're coded as systemic infection, getting IV antibiotics and PICC lines and OPEC. That's quite low rate of extraction. And no extraction or delayed extraction was associated with higher mortality in this group of patients. Another technique that I just want to mention, but obviously you guys know more about it than I do, is percutaneous mechanical aspiration. So sometimes you have these big vegetations and there's worry that if you remove the leads, they'll embolize to the lung. And in these cases, the angiovac or similar vacuum devices can be used to do percutaneous veggiectomy, and then you can remove the leads subsequently. This is the algorithm in those guidelines. We have already gone over all the scenarios and the cases, but this is just for your reference. Another paper that we recently published is we were trying to figure out, like, based on the Duke data, why is it that despite of all these guidelines, very few people are getting extracted? And what makes sense to us is that it's not the infectious disease doctors managing these patients in the hospital upfront. It's not EP cardiology managing it. These patients are admitted by ED and they go on the medicine floor and the hospitalists manage it. And if they're not thinking and connecting the dots that there is high-grade bacteremia or there's a high-risk organism in the presence of device, they won't even consult EP or ID. And then, so we need to focus on that. So in this paper, we kind of drew different kind of algorithms which are not focused on managing the infected cases, but how do you get from a patient with fever and positive blood culture to start to think that maybe the lead is infected and you consult ID or EP. Again, for your reference, I'm not going to go into details of it. How do you manage culture negative cardiovascular device infections? It's complicated. So the short answer is just consult ID and we will come and help you manage it. Chronic suppression, lots of failures, a lot of relapses, so we do not recommend it. In the MEDIC study, again, where we had 10 medical centers across the US, we looked at salvage success rate, and 80% was failure within 6 months. Again, suppression should be your last option if you cannot remove the device for some reason. When can you reimplant? If they're bacteremic alone and the bacteremia is cleared for 3 days, you can reimplant. If they have valve infection, we recommend to wait for 2 weeks because typically it takes a couple of weeks to try to sterilize those vegetations, especially if they're on the right side on the tricuspid valve and you're going to put a lead right through it to prevent cross-contamination from the infected valve to the lead. You should repeat blood cultures after removal of devices because Sarvat also looked at that and she found that 30% of the patients post-extraction had positive blood cultures, and that's what we talked about, that during the extraction, you can dislodge the biofilm and temporarily cause a sepsis-like situation. So if you don't repeat blood cultures, and we've had a couple of times where blood cultures weren't repeated, and the patient was on their way to the EP lab the next day and got a fever spike, and blood cultures were positive again. So you had to postpone the devices, or you put the device in, and the next day, you find out that they are bacteremic again. So repeat the cultures, especially for Staph aureus. There's a fair chance that they could be positive even on the day of extraction. If the infection is limited to the pocket, you can replace it as soon as the same day. So in this study at the Penn, they looked at patients who met certain criteria, which was that they had no fever, no leukocytosis, normal CRP, no systemic symptoms, and they were device dependent. So just local infection, nothing beyond it. So they extracted it, debrided the pocket, moved to the contralateral side, and put the new device same day. They followed them for 6 months, and they did just fine. So it is a reasonable option for these situations where the infection is definitely limited to the pocket. Those with high risk of infections who keep getting recurrent bacteremias, leadless devices, if the patients qualify for it, may be a good idea. Sometimes you can use leadless devices as a bridge. So somebody has endocarditis of the mitral valve or aortic valve, and you want to delay, dual chamber implantation for 4 to 6 weeks until the endocarditis is treated. You could consider using leadless device as a bridge if they don't qualify that as a destination therapy. These are less likely to get infected because of various reasons. First of all, they're smaller. The flow dynamics in the RV are different. The surface area is different. And they're coated with, and they don't have leads, obviously. They don't have generator. So contamination is less. And they're coated with parylene, which interferes with bacterial binding to the device surface. All right. Moving on to prevention. Simple things can be done to reduce the risk of infection. Nasal Bactroban, if used routinely, can reduce the risk of infection by 50% in surgical site infection. Chlorhexidine works better, so it's a better antiseptic compared to iodine-based solutions, so you should consider that. There's good data. It's kind of interesting that until 2009, there was no good solid data to show that antibiotics at the time of implantation can reduce risk of infection. So it was felt that it was necessary to do a randomized clinical trial. It was done in 2009 in Brazil. The goal was to enroll 5,000 patients, but at 500 patients, when they do interim analysis, it was very evident that the antibiotics have significant benefit in reducing the risk of infections. So it was, trial was terminated halfway through because it was considered unethical to not give antibiotics. So as a result, EHA recommends that you give cefazolin within an hour. You can give it on the way to the EP lab because just a push. But if you need to give vancomycin, then you need to time it correctly because infusion itself can take 60 to 90 minutes. And then there are alternatives if the patient is allergic to vancomycin or beta-lactams. Now, some people argue that because coagulase-negative staphylococci are a common cause of pocket infections, and 80% of coagulase-negative staph are resistant to beta-lactams, that why don't we use vancomycin as the go-to drug for prevention? I mean, in theory, it makes sense. However, the data shows otherwise. Here's a randomized clinical trial done in Israel on cardiovascular infections. It's not specific to PSR ICDs, but in general. And vancomycin was inferior to cefazolin for treatment of MSSA infections. Exhibit B from Australia, 22,000 patients, data was collected prospectively. And what they found is that use of vancomycin for prophylaxis was the independent predictor of higher risk of infection compared to using beta-lactams. So therefore, you do not want to routinely use vancomycin for every patient. If patient is colonized with MRSA and you're worried about it, give the vancomycin in addition to cefazolin. Give them both. If you need to operate on the pocket again because they got a big hematoma or the device is not functioning properly, you need to reposition the lead or something, they need another dose of NSAF at that time. Secondary prophylaxis for dental procedures and stuff like that, there's absolutely zero data that it's necessary or helpful, so you should not do it. Same is true, by the way, for prosthetic joints. But we know that people give antibiotics, but it's unnecessary. It's probably not necessary for endocarditis either, but that's a different topic for a different day. What else you can do to try to reduce the risk of infection? So this padded trial was mostly in Canada. There are 28 centers, and it's a cluster randomized trial. So they're not randomizing patients, they're randomizing institutions. So out of the 28, they say 14 will do these extra things for 6 months, and other 14 will do standard of care. After 6 months, we'll switch. So these hospitals will start doing extra things, and these will go back to doing standard of care. So what are those extra things? They would give them vancomycin routinely in addition to NSAF, wash the pocket with antiseptic solution instead of just saline, send them home on oral antibiotics for a few days to prevent pocket infections. So did it work? Was it helpful? The short answer is no. Doing all these things routinely does not benefit the patient. So unless there's some situation where it makes you think that it may be helpful, you could consider it, but not routinely. The other thing you could consider in patients who have recurrent infection or high risk for infection, poorly controlled diabetes, dialysis patients, immunocompromised, on steroids, is to consider these antibiotic envelopes which have, minocycline and rifampin impregnated in the envelope. And these can be helpful. The initial command trial was done in 2011 to show that they were safe to use. Then there were two prospective studies, Centurion and Citadel, which also showed that the use of envelopes was helpful to reduce the risk of pocket infections. The problem with the first generation envelope was that it would induce a lot of fibrotic reaction. You'll get this thick, big, dead space capsule around your device. So when you need to revise them, it became a nightmare, and they would get more infections. So then the absorbable envelope was developed, which disappears after 8 to 10 weeks of implantation. It was studied in rapid trial, which was published in England Journal and JACC. 7,000 patients were enrolled. And where it really was found helpful, if you have patients with pocket infection with Staph aureus, then use of envelope can reduce the risk of staph infections of the pocket, which is really what it's designed for. It does not prevent late onset lead infections because it's not on the leads and it's already gone after 7 to 10 days. Additional types and different materials of envelopes, different techniques of manufacturing. So a third generation envelope is out there, kind of works the same, associated with less migration of the generator. Then there are these biologic envelopes. They're made with pork intestines. You take them out, you decellularize them, you soak them in antibiotic solution. There's good animal data that they can be helpful to prevent infections. In this case, it was gentamicin, and reduce the risk of infection, similar to the other envelope. Then this subsequent study, we looked at minocycline, rifampin, kind of similar model, and kind of showed the same thing. Here's a review just for your reference, because we were trying to figure out where are the gaps in care. Is it in diagnosis? Is it that we don't know the risk factors? We're not consulting the right teams? And this review kind of puts it all in context to give you some ideas about how to put together the team to manage these complicated infections. The new Heart Rhythm Society guidelines are in the works. They will be published hopefully beginning of next year, which will address, the new data, the new questions that we have since the prior guidelines. And currently they are being reviewed for endorsement by all of these societies listed on the other side. So take-home points, what I want you to remember, if you don't remember anything else, is that timely diagnosis and removal saves lives. In patients who have gram-positive bacteremia and a device, think about device may be infected and do the appropriate workup. Complete removal is necessary to cure it. Partial removal or no removal does not work. And a gram of NSAF is worth a pound of cure. And finally, I just want to show this slide. You have the great one on the left, my mentor, Larry Bedur, but then Walt Wilson, Jim Steckelberg, all these residents and fellows and faculty who in the last 20 years I've had the privilege to work with, and who've been really helpful and transformative in changing our understanding of how to diagnose and manage these infections. And it's because of hard work of all of these individuals that I'm standing here taking the credit and giving this grant round. So just want to thank them all. And thank you for listening.